Daniel McCabe. Thank you, Daniel, for joining and kicking things off for us today in this session. I'm just going to bring your slides up here, and I'll let you take things away.
Thank you, Peter, and hi, everybody. Really great to be here. For those that don't know me, especially all of our international guests, my name's Daniel McCabe. I work in the Department of Health, Disability and Ageing, and I look after two major things in our national government. One is our Medicare program, which is our national health insurance scheme for all Australians, and then also look after digital policy as well for all the things that we do in digital health. So I'm really excited to be kicking off today's discussions, and I'm going to set the scene talking a little bit about the Australian context and some of the things that we're doing here in Australia. But I might just start by acknowledging the traditional custodians of the lands that we're meeting on today. And for me, that's the Ngunnawal people. And I want to pay my respects to elders past and present, and also just acknowledge any Aboriginal and Torres Strait Islanders that are joining us here today. As I said, I'm really excited about the work that we're doing in the digital space and the work that we've been able to achieve in the last few years with the Spark program. And I'm just going to step through today some of the things that we're doing that links to our broader reform agenda. So if we go to the next slide, I just set the context by talking about the reforms that we're doing here in Australia. And I think firstly, I just want to start by explaining, and I guess for many of you, you would appreciate this, and some may not know this, that Australia does have a world-class health system. Last year, we were fortunate to be reviewed as part of the Commonwealth Fund's review of high-income countries and ranking them in terms of their health system performance, comparing us, we were ranked #1, and we were compared to 10 comparable countries in Europe, the US, the UK, and New Zealand. But like most countries, we face many challenges in our health system that we need to work through. And they include ongoing challenges with workforce and huge demands on our hospital systems, an ageing population like most countries around the world. And in the Australian context, fragmentation of care across all of our different settings, which makes it difficult for people as they move through our health system. And then also, like many countries, we have a large percentage of our population that are dealing with one or more chronic conditions that we're looking after as well. So addressing these changes addressing some of these challenges requires change to the way we think about healthcare in Australia. And that includes work that we're doing to redesign our funding models to really start to think about how we better support multidisciplinary care, but also support the more complex care that we need to do with our population. We're doing a lot of work around supporting our healthcare professionals work to the top of scope of practice, and digital tools are going to be critical to support them. We are really focused on enabling Australians to have much more agency in their healthcare by providing critical information to consumers in their hand about their healthcare journey. And also we want to really improve the way that data is collected and analysed across Australia's healthcare system to inform our system planning, population health issues, quality improvements and feedback loops to enhance healthcare in Australia. Digital health is a critical enabler for all of these things in our reform agenda, so supporting multidisciplinary teams to collaborate and communicate together, ensuring health information seamlessly is collected and shared at the point of care. It's really going to help us enable new models of care, including funding arrangements, and modernising connections for referral pathways to ensure consumers' health information follows them no matter where they present in our system. Over the last few years, Australia has had a number of reviews of our health system. And one of these reviews has recognised that a digitally enabled workforce will be critical to realising this effectiveness and efficiencies that we need across our health system. To support patient-centred care and a more connected system, this review recommended that all 9 Australian governments, that's our Commonwealth, state and territory governments, commit to progress in digital health to improve health service integration, clinical decision-making and transitions of patient care. It's also encouraging us to look at better data collection, curation and analysis of health data assets to support an efficient health system and enhance equity and patient outcomes. Our government is also focused on improving productivity across all parts of our economy, and digital health offers one of the most significant opportunities to realise productivity gains in healthcare. And these include reducing duplication in healthcare, improving access to healthcare, really supporting early intervention to keep Australians healthy, real-time insights through data, and feedback loops for better planning. So we're really working hard to drive some of these reforms and shape the future of data and digital to enable all of this. Next slide. We have made some significant progress, as I said, over the last few years, but we still face challenges. Digital information sharing is improving, but it's still inconsistent and sometimes burdensome. In our context, 18 to 24% of GPs and public hospitals share information across those settings using digital systems, which is not nearly where we need it to be. Unfortunately, worldwide, 75% of fax traffic still is coming out of the health sector, and I think that again is something that we really need to challenge. 40% of our GP's time can be attributed to administrative burden. Clinical information systems are still largely siloed in Australia, and there are variations of digital maturity across our healthcare sector. Many of our allied health professions are not using clinical information systems to manage patient information, and some healthcare providers don't have the time to really work through how to integrate and leverage digital health tools to support care delivery. And many Australians are continuing to experience poor navigation and access to health services. For example, 49% of our patients that are discharged from hospitals experience adverse events in their continuing care due to delays in sharing information relating to their discharge. We are working hard to address these challenges and will require ongoing collaboration across our health sector. Next slide. The Australian health system is complex, with more than 1.1 million health professionals working across our public and private health services, delivering healthcare every day to 27 million Australians. The Australian government is focused on connecting all parts of our health system to improve access and experience for all Australians. In 2024, we celebrated the 40th anniversary of Medicare, our National Universal Health Insurance Scheme. Medicare has changed significantly over the last 40 years, moving from paper forms and fax machines to being almost 100% digitally enabled through claiming. But it too needs to evolve to support more complex care and move away from being an episodic-based model of funding. And so we were really looking at how we use all of the work we're doing in Spark and our digital initiatives to also modernise the way that we pay for healthcare services. More Australians want to be involved in their healthcare, have person-centred services, have complete and accessible access to their health records. To achieve this, our health system must modernise and use digital tools that are user-friendly, safe, secure and integrated. We are striving for a modern health system that provides a connected care experience where health information is organised around a consumer, is accessible to all of their healthcare team, no matter where the care is provided. Next slide. Better organising health information around a person so it can follow them through their healthcare journey for 27 million Australians is no small feat, but it is, in my view, a worthwhile endeavour, because when a consumer and their healthcare team have access to the right information at the right time, it improves the safety of clinical handovers and enables a more seamless transition of care. To do this, we're working closely with our delivery partners at the Australian Digital Health Agency and the CSIRO to deliver key pieces of work that will enable this experience, including providing consumers and healthcare providers the ability to establish and identify their multidisciplinary team care through digital channels that are seamlessly integrated, such as our My Health app for consumers, and modernising and changing clinical systems for providers. We're looking at national approaches for health information sharing that enables communication flows between patients and their care team, as well as sharing key health information such as care plans, results and referrals to our national My Health record system. To support this, we are also working with our software industry to uplift connections to Australia's My Health record. This has started with our allied health sector and our residential aged care sector, but we are looking to ensure that all parts of a consumer's healthcare team have access to their health information in My Health record. My Health record is being modernised to collect and store data based on FHIR and really leveraging the work we're doing through Spark, and also been modernised to support standards-based terminology such as SNOMED CT for coding. We are working through Spark and the modernisation of My Health record to introduce a national patient summary. A patient summary is a standardised collection of patient information that is dynamic by drawing on information from multiple sources across the health system and presenting this to both consumers and their healthcare team in a meaningful way that is tailored to the patient's need at the point of care. We're also looking at how we can improve the flow of medication information in all of our clinical handovers and transitions of care. Because today, with 50% of medication-related hospital admissions are considered preventable, we are looking at how we ensure that we can manage medication better in Australia. Next slide. We are continuing to build seamless digital pathways to improve the consumer experience, whether that be the work we're doing on prescriptions, diagnostic and pathology tests, and referrals. This includes making it easier for Australians to find a service that meets their expectations on cost, location, and other preferences. We are also working with our national prescription delivery service to enable this with FHIR-based APIs to modernise medicine workflows across all of our health system. This will help improve access to medicines as well as improve clinical safety. We're also now starting to turn our attention to addressing e-referrals, which allow Australians to actively engage and participate in their healthcare. We are looking to expand the role of multidisciplinary care teams within primary care and considering the possibilities of new referral pathways. This work will ensure that relevant health information supporting a referral is available to those that need it. It will facilitate notifications of key information or even results in real time to consumers and members of their broader care team. A national e-request capability has also been scoped with requirements identified, and we're working through that investment with government to make sure that we can fund that ongoing. The Spark program has been critical to the work that we're doing in that space in terms of capturing and laying the groundwork for our national e-requesting capabilities. Under our Health Connect program, all jurisdictions, all states and territories have agreed to establish a national directory capability that will serve as a trusted single source of providers in Australia to help enable better information sharing. Establishing the directory is the first step that we are taking in establishing a national health information exchange capability, which will allow us to move information between care settings across Australia's healthcare system. Over the last 12 months, the department will start commencing and looking at work for our technical and policy opportunities to enable digital referrals across primary care and aligning our work to the scope of practice review. As I mentioned earlier, patient summary is going to be critical to all of these things to make sure health information from multiple sources can be centralised to support access to the broader care team. And a dynamic patient summary means health information regarding a patient's problems, allergies, medications, procedures, immunisations will be available to not only consumers, but also their healthcare team in real time to support referral processes. Digital processes such as pathways such as e-requesting, e-referrals and patient summaries will guide and support consumers from referral creation to provider selection through to result sharing to enable a much more connected and user-friendly experience. Next slide. So Spark, which is really what we're all here to talk about today, represents how we bring technology together with people that need to use it to ensure that we can improve the health and well-being of all Australians. Spark is a true demonstration of collaboration. It has over 1,000 participants, including clinicians, consumers, software vendors, and all 9 governments working together to establish a nationally consistent set of data standards and clinical terminology for the capture and exchange of key health information. Back in April this year, community expert time was exceeding nearly 20,000 hours across our online and in-person Spark working group sessions, showing a strong commitment to its success. Within the first 12 months, the first core patient health information standards were published and are now being built into clinical information systems nationally. Last year, we released the Australian Core Data for Interoperability Release 1. It's a dynamic artifact that evolves with the addition of new clinical data groups. It serves as a foundation for health data interoperability in Australia, and it's aiming to standardise the capture, structure, usage and exchange of health data to address fragmentation across our health data systems. It is poised to become a national asset, focusing on creating an independent foundation of reusable, standardised information models and related artefacts. The Spark program will continue to develop the remaining AU core and e-requesting FHIR standards, which are set to be published in June. This work is critical for creating end-to-end digital pathways for requesting and referrals. Looking forward, we are also focusing on developing the National Patient Summary, event summaries, and standards for supporting chronic condition information sharing. Next slide. Lastly, we are starting to make some significant strides towards a learning health system where clinical data collected at the point of care can be used to generate insights to enhance patient outcomes and promote sustainable cost care models. Redesigning Australia's funding models to better support multidisciplinary team care begins with identifying and systematically measuring outcomes. We are working with the Institute of Health and Welfare, which is our national data agency for health and welfare, to leverage Spark to build out our national healthcare data standards, which will support us with service delivery planning at a local, state and national level, support healthcare professionals by creating feedback loops so that they can deliver true value-based quality care, and providing patients with information they need as a way to inform our multidisciplinary care pathways. Next slide. So what does the future hold for us? How will improved information sharing transform our healthcare system? It means that having the right data and information available at the right time and through the right person. Multidisciplinary care teams will have instant access to a patient's comprehensive health history. Consumers will have full control over their health information, and different healthcare settings will be able to communicate seamlessly with each other. This will reduce the burden on our health system and provide data-driven insights to help improve health outcomes in Australia. Ultimately, we will achieve a secure, efficient, and accessible learning health system for all Australians. Next slide. So the journey towards a digitally enabled healthcare system is both challenging and rewarding. We've made some significant strides, but there is still much to be done. And I really look forward to working with all of you as we look at how we can collaborate to embrace digital transformation and focus on patient-centred care as we create a modern, efficient and effective, equitable health system for all Australians. Thank you so much, and I look forward to today's discussions. Peter.
Hey, Daniel, thank you so much for providing that opening as part of this session one. We're firing around the globe. I'm going to ask you to hang around for a little bit because we're going to hear from other parts of the world. We're really leaning into the benefits of virtual to take some of that in context, and then we'll discuss it in a little bit of a panel as those comments and questions keep running through from attendees. So if you're in the chat, keep those coming through. But Daniel, I'll speak to you soon.
Thank you.
As we move around the world in session one of this Sparked Symposium, we move from Australia to the US, and I'm joined by Steve Posnack. Steve, thanks so much for joining us.
Thanks for having me, Peter.
Always a pleasure. I feel like it's been a while and looking forward to hearing from yourself. I'm just bringing your slides up here and I'll let you take it away.
All right, thanks very much. Appreciate the opportunity to join everybody today. I was given about 10 minutes, and so I decided to tune my compression algorithm to do 10 years in the next 10 minutes. So I'm going to take you on a bit of a journey for how the United States has approached fire and the ways in which we've engaged both from a public-private partnership perspective, working with industry, working with government, iterating on our regulatory work, the different standards development organization activities, and I will just jump right into it because I'm already behind on my compression algorithm here. You can go to the next slide. So I wanted to start really in 2015, and so you'll see there at the kind of left of my timeline that we were aware of fire, the earlier versions of the releases, and we didn't think that it was quite ready to regulate and require across the nation a specific version of fire. The industry, in fact, told us it's a little bit premature. If you lock us in now, it'll actually do more harm than good in setting a baseline. And so the approach that we took was to set what's called the data for functional API requirements. And so we specified the types of application programming interface performance that we'd expect in a way that I like to describe at that time to allow for but not require fire. And so we let the industry decide which standards it was going to use. But we knew that a lot were already from an EHR and health IT developer standpoint going forward to try and use FHIR to meet these specific regulatory requirements. We kind of left that flexible and open for the industry. And so along that timeline, you had what's called the 21st Century Cures Act that was passed at the end of 2016 in the United States. And that really created additional legislative incentive for us to adopt requirements for standards-based APIs. If you can believe it, that was specified in our legislation. Sometimes you see that it was described that it needed to be done without causing special effort on the part of those that interact with those APIs. So some interesting policy-related dynamics to weave into the technical work that we were going forward. At the bottom there, the second one, I'm sure many of you are familiar with the Argonaut project out of HL7. That really served as the, for the computer scientists out there, version 0 of our, what we call now US Core. I saw that on Dana's slides, a lot of similarity or symmetry between the Australian naming conventions and the ones that we've chosen at this stage. So we had this early work from industry, the Argonaut project, a lot of interest and adoption as that was driving. I highlighted that in 2018, those of you that are iPhone users, Apple included, FHIR-based ways for patients to get access to their health information and built it into iOS 11.3, which seems, forever ago now. And the line across the top going from 2015 to 2019 is reflective of the time that it took for the functional APIs in industry to get adopted and developed and rolled out and put in the hands of healthcare providers for their use in our, it's called Centers for Medicare and Medicaid Services, or CMS. They're the other federal agency as part of my Department of Health and Human Services that creates the behavioral payment incentives for healthcare providers to use this certified technology that includes our regulated requirements. And so you had that 4-year time period where a lot of action was happening. A new legislative statute was put into place. You have industry adopting things. And at the same time as that first rollout of functional APIs came about, HL7, with work and investment from us, and I know you'll hear from Dan in a minute, we first put out the version of what we call US Core, which is reflective of that initial data set that we had created as well, which we call the United States Core Data for Interoperability. And this is the first version that's built on FHIR Release 4. And so going forward from 2019 onward, we really have some stability in terms of the FHIR-based release that a lot of our specifications, even to date, are continued to be iterated on, even though the standards development organizations, the community going forward through HL7 is, continuing to iterate. I know FHIR is talking about release 6, coming up in the next year or so. But in terms of implementation and execution, that's really a FHIR release 4 platform at this stage. So you can go to the next slide. What I wanted to show is as of this date in 2019, so, rewind your brains, we had a lot of momentum just from specifying the functional regulatory requirement, not a standards-based regulatory requirement yet. But because of the way that the incentives work in the United States for all of the hospitals, in this case especially, participating in those payment programs, think behavior change, the health IT products that they were adopting were being deployed and developed by FHIR-leaning health IT developers. So the Epics of the world, the Cerner, Oracles now at this stage, a variety of others in the United States that have been early participants in the FHIR process, and we're starting to build it into their underlying software design. You can go to the next slide. And I just wanted to give you a sense of what US CDI version 1 looked like at that time as well. So not too many data elements there. I would note, if you want to check out our website there at healthit.gov/USCDI, we are currently in the process of fielding for draft version 6. And this is an annual process where we're adding data elements to the US CDI. I think we're over 100 now. And that is, for all of you that are clinicians, just a drop in the bucket in terms of the amount of data that you could obviously represent in FHIR and then build into particular regulatory requirements. But we had to start somewhere, and we've been looking to iterate on that every year over time. So you can jump back to our timeline here and wrapping up with the next, there we go. The next kind of 6 years following looks like. Again, as we went through the regulatory cycle in 2020, this was a rulemaking that was attached to the 21st Century Cures Act. So again, you see the statute was passed right at the end of 2016. So let's say 2017, 2018, 2019, we were doing the regulatory work to put it out for public comment, get those comments back, write all the regulatory requirements. In that time period, we built into what we call the Cures Act final rule that came out right basically when the pandemic started. You had the adoption of the United States Core Data for Interoperability version 1. You had the US Core implementation guide for the first time based on R4. We also included what we call the bulk fire implementation guide. So US Core is generally applicable for the N of 1 cycling of patients, other types of services that revolve around a single patient focus. We also included the bulk fire implementation guide so that groups or cohorts of patients could be requested in a standardized way. And, for those that track privacy and security related requirements, we also have a full suite of those things. I just put in there Smart on Fire as one of the implementation guides that we've adopted. And the thing that we've dealt with from a regulatory perspective is, again, it's a little bit of hurry up and wait. I often feel like I'm giving the teaser trailer movie coming attractions for the next blockbuster movie that is going to come in 3 years. And so exactly to this timeline, we finalized the rulemaking in early 2020, and we gave the industry, in part because of pandemic response, et cetera, up until January of 2023 to get their implementations done, to roll them out to healthcare providers and get those FHIR APIs into the hands of the healthcare community. And so it really hasn't been that long since the kind of standardized FHIR-based APIs have been in production. It's really been about 2 years. And as a regulatory agency, as a standard setting agency, we kind of rinse and repeat. We went through a rulemaking in 2024, which we call HTI-1. We started to number them like space shuttles, I guess I'd describe it, where we updated the US CDI version to raise that baseline. And also our work with HL7 now has created this annual process where we put out a new version of US CDI. The HL7 community responds and they create a new version of US Core that can support that version of US CDI. And those kind of work in lockstep together over time. And so we adopted those new requirements to raise the baseline in 2024. And that will be required as of January 1st of 2026. And so this is a story, again, just to kind of cap things off, where we've done a lot of engagement with industry. Sometimes we've listened, sometimes we've pushed a little bit harder. But we've found ways to iteratively cycle through and raise baselines as we've gone through the standards adoption process, investing in HL7 to make sure our policy priorities are being met, and then ultimately set deadlines that the industry was able to implement toward, and I would say, meet with success. And so happy to answer questions as we get to the panel, but that'll be it for me at the moment. You're welcome to get in touch at the end. Thanks.
Steve, that compression algorithm is on point. You hit the 10-minute mark exactly, and I can see in the chat that was it's well appreciated to have your perspectives on this too. But I'm sure we will unpack that a little bit more when we get to the panel. So hang around for a bit, and I'll speak to you shortly. As we continue to fire around the globe in session 1 of the Spark Symposium, I'll bring on to the stage Abhi Kalra, and he will pop up on my left. That's my left there. Hey, Abhi, how you going? We'll just unmute you when you're ready to roll. There we go. You'll have to do that. Amazing. I can bring up your slides if you like too, and I'd love to learn more about Canada. So over to you. Thank you.
Good morning, everyone, and thank you, Peter. Great presentations from Daniel and Steve. My name is Abhi Kalra. I am Executive Vice President at Canada Health Infoway, based out of Toronto, Canada. This is 7:30 p.m. here in the evening, but I must tell you, listening to the speakers and listening to attending this Gates wonderful baby, I'm all fired up. So let's get going. I'm going to cover a little bit about, what Canada Health Infoway is about. I will also cover our digital health mandate and explain a little bit about how the geographically the health systems work within the Canadian landscape. So if we could go to the next slide, please. Canadian landscape, 14 different unique health jurisdictions, 13 provinces, territories, and then the federal organizations. Each one of them have their own accountability and responsibility to manage healthcare delivery within their regions. We deliver care through about 1,000 hospitals, about 100,000 physicians, 500,000 nurses, registered nurses and nurse practitioners, and over 11,000 community pharmacies. And we, at any given point, we work with about 100 plus unique healthcare solution providers, partner vendors, in the healthcare space. And a lot of these names are international, some of them are local, some of them are regional. So you can imagine the complexity of the vendor landscape that we work with. And when you look at that, some of the conversations that we heard from Daniel and Steve, the common language, the common way to exchange information, which is FHIR, it becomes very, very important, because you got to actually move to common standards to sustain the cost for our healthcare system. If you can go to the next slide, please. So Canada Health Infoway, we are a not-for-profit, federal government-funded central agency, and we work with all the 14 different health systems to convene, align, and coordinate their stakeholders on common connected care priorities. Our mission remains very focused over the last 2 decades, which is to continue to advance the digital health progress within the country, making sure that all Canadians have electronic access to their health record, and our health system remains connected, where the information could flow from one setting to the other setting during the circle of care for patients. And how we do that is we work very closely with, of course, all the public stakeholders, but we also work very closely with all the private sector. Private sector are very key in terms of catalyzing the change or catalyzing the transition from a pen and paper to a digital system, and now from a digital system to a connected care system. And in our role, we also have a forward-looking view of, what are some of the innovative areas that we need to focus on. So as an example, how should we look at integrating AI into the healthcare delivery? So these are some of our connected care goals from an organization standpoint. If you could go to the next slide, please. What we did about 3 years back is, in order to align all the health systems, which maintain their own autonomy, to make sure that we're aligned on common priorities, we worked with them, and what we published was a public document called Shared Pan-Canadian Interoperability Roadmap, and it was really centered around 4 key goals. One is, how do we reduce the data blocking within the healthcare systems, within various IT health systems? And we all know some of that is intentional, some of that is not intentional due to lack of standards. The second goal is to improve the provider access to patient data at the point of care. When you go from one setting to another setting, whether you have a family doctor or not, whether you go to a walk-in clinic, how do you actually make sure that the information about the patient is available at the point of care? Third one, continue to make sure that the citizens, the patients, have access to their electronic health record. And we use primarily government or provincial portals, that every single region has been establishing to provide access to their citizens. And finally, improving care coordination and collaboration. How do we make sure that the multiple healthcare providers during the circle of care have information, same information to provide care to the patients? And some of the initiatives specific, so these are the goals, and we launched national projects or programs to start measuring these goals. Primary care data portability, the couple of standards that you heard from Daniel and Steve, core data set for interoperability and CA core. These are national standards that we're developing in collaboration with our stakeholders. Patient summary, you heard a lot from Daniel, and Canada was one of the early adopters of patient summary, making sure that we have a national standard around how do we collect and curate information about patient from various sources and make that available. Patient access to electronic health record, where we've defined what should be the strategy around access, but not only access, be able to also make changes to their own record. So that's a strategy that we work on together. And finally, from a collaboration standpoint, again, e-referral and e-consult, there has been a great push over the last couple of years to move the referrals and consults and lab requisitions from a paper acquisition to a digitized system. And those are specific, measurable, tangible projects, that our health system, individual health systems are moving forward. And then at the bottom, you see some foundational capabilities that are required either in the data space or in the technology space or in the privacy and trust framework. So that's a collective approach, taking both top down as well as a bottoms up approach to make sure that we're able to not only deliver the work but also measure as well. Next slide, please. I already touched on, and the way we coordinate all of that is it's very similar to what Steve described for USA. In Canada as well, we play that role of the coordinating entity where we work both with the public and the private sector to co-develop our standards, ensure that clear conformance requirements are established, and help guide the regional and the local networks to develop exchanges so that the information could be exchanged. And as a result, the two objectives continue to make sure that our health IT systems, are leveraging the modern standards like FHIR for exchange, and then making sure that the data sharing between the healthcare providers, between the owners and the custodians, could be actually managed, and that really is a central role that Canada Health Infoway plays as an entity. Next slide, please. This is a very important element, and I think the team wanted to make sure that we emphasize on this one. This is something that we started several years back, is to form that industry collaborative. And this is an industry collaborative. Not all of them, may or may not have contractual agreements with Infoway or other organizations, but they're at the table and they help us guide. So think of it as a consultative body that would guide on various topics, for example, related to legislation, related to guiding some of the priorities for the country, but also putting down some challenges. What are some of the challenges that we need to tackle to make sure that we make the private sector more equitable and more competitive in the Canadian landscape. And one of the key highlight that we came up last year was an industry charter. This was a charter that was developed with the private sector, and there were some foundational principles to that around data blocking, around principles like, we will strive not to block data that is required for patient treatment and patient care. So these are some of the guiding principles that we put around that. So this group seems to be working very well. We meet once every quarter to review the progress and also review the challenges that either as a group or as individuals they're facing. Next, please. I think both presentations, you heard the common acronyms, AU CDI and US CDI, AU Core and US Core. So clearly that basically shows that digital health space, as much as it is. It used to be local and then national, but now it has become international because we share common problems, and often, we share same solutions. In some cases, we follow the best practices. In this case, I think US started off this work many years back. So I think some of the countries like ourselves are following some of the best practices and lessons learned from that. So we are similarly working on one core Canadian national data set, which will be a core data set for interoperability, and also CA Core, which really defines how some of those data will be exchanged, using the FHIR profiles. And that has been a big push over the last couple of years. And this is something, that when we look at our legislation, both federally, also within the individual regions, these are some of the standards, that will look to mandate and will look to make sure that, we address the fragmentation of the various standards within the various health systems. So yeah, similar journey, but you can see that, we're all trying to follow a similar pattern there within the digital health space. Next, please. Perfect. So I didn't have a compression algorithm, but I relied on my own watch on my computer, and hopefully I finished that, within the 10-minute mark. Thank you. Thank you for the opportunity to come and present.
You were a very time-conscious human in the loop, Abhi. So, no, wonderful to hear that. And there's been some great feedback and questions, which no doubt we'll be able to dive into a little bit in the panel session in just a second. But we'll continue to move around the world. So I'll come back to you shortly.
Okay.
Now, I feel like it's important in this session 1 here at the Sparked Symposium, as we're firing around the world, to get the perspectives this time from HL7 International. So I'm going to bring onto the stage Daniel Vreeman, and thank you for joining us. I feel like I need to get you to, I feel like I'm introducing a band or something here, given your background. But virtual backgrounds tell 1,000 stories of someone's context. But unfortunately, well, just as fortunately, we'll be able to hear from other topics from you today. Daniel, I'll bring up your slides now and hand over to you.
Perfect. Thanks so much. It's really a pleasure to be here with all of you. And I am Dan Vreeman, Chief Standards Development Officer at HL7 International. But for the purpose of this panel, I'm serving as the anchor leg Daniel. So glad to be with you. From HL7's perspective, I wanted to begin by just saying that all of our success and the progress that we're making in standards development is really because of the thriving community of participants that are driving this work forward. And I welcome and include all of you in that community as well. What you can see from this graphic is that really this is an active community drawing from participants coming from nearly every corner of the planet. This journey towards interoperability is truly a global experience. And just as a snippet into what sort of happened recently within HL7, you can see that the growth in community participation has continued with just in the last quarter, the beginning of the year, around 2,800 new people have joined from over 100 different countries. And so we continue to welcome those participants into this process of improving data availability and access for all. A couple of weeks ago, I guess it was the week before last, HL7 International gathered for its triannual work group meeting and FHIR Connectathon, which is where we get together in person to both improve the specification, but also to test implementations and their ability to make real the specifications that we're developing it. And cribbing from my hometown of about 17 years, Indianapolis, Indiana, which hosted a kind of a big race over this past weekend, which they call the Indy 500 the greatest spectacle in racing. Well, we like to call the HL7 work group meeting the greatest spectacle in interoperability, because it really is a truly remarkable event where participants from all different roles and backgrounds come together for this joint purpose of improving the interoperability of the systems that we use. One of the themes, I'm going to cover a couple of the themes that sort of emerged or came through in this meeting, but one of them that really came out was, sort of this translation that happens between international level or pan national initiatives into national initiatives and even into jurisdictional efforts, as we heard from the community of Madrid, from the nation of Spain, as well as the impact and driving forces of things like the European health data space that are having sort of across nations. And it's truly remarkable how how important it is to collaborate and to harmonize and to try to align these different things, but that really sort of the scale that can be enabled by open standards-based approaches is quite remarkable. As an organization, HL7 International has been engaging in a strategic planning initiative. And for any of you who participated either in HL7 International directly or via the affiliate, hopefully you had a chance to provide some feedback on this. But our board approved a new sort of strategic direction for the next couple of years, which is really focused on helping ensure that our work as a standards development organization continues to meet the needs of all of the different kinds of stakeholders that make use of and contribute to our specifications. In addition, being able to draw in and have recognition from the appropriate entities about the importance of standards and interoperability-based solutions to ensure that our work is sustainable for the long run, and so that it has a foundation upon which the specifications, the community supporting them are really built to last, and that we continue to undergo sort of digital transformation ourselves in the way that we create and manage standards as well. But none of that changed sort of our fundamental focus, which is advancing the availability of health data when and where it's needed. And HL7, approaches this work with a true recognition that interoperability begins and ends with implementer communities, and that really standards development and standards implementation go together hand in hand, forming a virtuous cycle. And so the feedback that comes from things like testing events and from the discipline of creating open source reference implementation software that feeds into a standards development process are important parts of the journey, but that once a specification is live, the real learning, the live learning, continues, and we are committed to making sure that that feedback from end users gets brought back into our standards development process so that we can continue to make those specifications better fit for purpose. And to do that takes many, many different kinds of participants. I have here on the slide sort of a view of the many, what I call integrated components of HL7's global community, including our members, the important role of our affiliates, now numbering around 40, our regional partners, where we're actively trying to build capacity in developing FHIR-based open standards solutions in regions around the world. And of course, the global HL7 FHIR Accelerator Program. You see here sort of the icons of those communities of practice, which are all committed to working together as collections of stakeholders who have a shared purpose of using FHIR for a particular kind of interoperability problem. To give you a sense of where the FHIR community is in 2025, I put on here just a gathering of some of the example use cases of how FHIR is being used, actively developed specifications and applications of the FHIR standard. And you can see as you kind of glance across this, there are many, many different use cases and levels of scale at which FHIR can be applied. And the really important thing to recognize is that FHIR is this foundational capability. And so the investments that are being made at the level of core national specifications are paying dividends as new use cases for that same foundation emerge. One of them that you heard several of the other panelists talk about is that of the patient summary. And the International Patient Summary, of course, is a well-known suite of standards. HL7 serves as the SDO home for two expressions of the IPS, including one based on FHIR. And we continue to advance that work, both in terms of the specification development. There's a new version sort of underway right now, but also in terms of tooling to support implementers through enhancements to the validator and reference implementation software, as well as even the FHIR IG publisher itself. Continuing to host FHIR Connectathons where solutions can be tested against this. We did this in Madrid just about 2 weeks ago, as well as through our participation in the international SDO scene through a group called the JIC, the Joint Initiative Council, where we participate in outreach events such as those listing sessions where what we're trying to do is gather different stakeholders to hear about how we can best together collectively as a group of SDOs and with our partners, steward the ongoing evolution of IPS as a truly global good. We held one listening session at the HIMSS event earlier this year. We're going to be having another one at the HIMSS Europe event, and I'll be hosting one at the MedInfo conference coming up in Taiwan in August, I believe it is. And any of you who have interest in providing feedback on the IPS of those forums would be very much welcome. So to wrap up, I want to give you a couple of things to sort of keep your eyes on. First, of course, is the evolution of the FHIR standard itself. We are moving through a series of informative ballots, and we're now getting ready for the first normative ballot. And so the new sort of uplifted version of FHIR Release 6 is on schedule to go out for that normative ballot at the beginning of next year. I also wanted to mention, for you to keep your eyes on a new technology that's already been through ballot. It is now in the process of ballot comment reconciliation with an anticipation of publishing later this year, called Smart Health Links and Cards. And this is a technology that enables easy sharing of verifiable, non-tamperable health data, whether a small bit such as can fit in a QR code, or a larger collection such as the patient summary that can be linked out to, using very simple sort of consumer-friendly sharing mechanisms. And we really think that this kind of technology will be important for enabling a very wide range of use cases, including, as we've already seen, with patients who are moving geographically for things like the Hajj. Of course, within HL7, we've been keen to engage with and try to leverage AI in a variety of ways. And there are three things I wanted to quickly mention. One is a new report that came out just last week or so on reducing fraud and improving payment integrity, and the way in which standards and data enabled through technologies like FHIR combined with AI can really help in this problem space. As I mentioned, we're interested in improving sort of the way that we do things at HL7 using AI, and we're launching an internal process to help folks engage with the standards development process through an AI chatbot tuned for our specific procedures. And then third, announced just today, I believe, is our AI challenge, where we are calling for individuals, organizations, government entities, anyone who is developing AI solutions that make use of HL7's open data standards. We would love to hear of the innovations that you all have come up with through this challenge. The winner will be announced at our plenary meeting later this year. There's no cost to participate, and we'd love to hear about your innovations. So with that, the last thing I want to mention is just this closing idea that you all are part of our merry band, and we're glad that you all are here. So thank you so much.
Dan, it's been great to see what's been achieved and what's ahead. I'm really looking forward to bringing everyone who's just presented in the last hour or so on, and we can dive into a little bit more. Thanks so much.
Thank you.
Okay, and now we've got the panel here, and I've been keeping an eye on the chat. Those in attendance live, thanks for the suggestions for questions and comments. And as those presentations have come through, we started off with Daniel McCabe in Australia and went around to Australia and Canada and saw from the HL7 International perspective as well. Some consistent themes coming through generally, but Daniel, I might pull some moderation rank myself, and just a question that came to mind too as I saw those questions coming through, because it's great here at this Spark Symposium. We've got frontline clinicians who are in attendance, and we have the whole ecosystem, and we're talking about building solutions and standards and having legislation that's relevant at a local context, but we've got this global alignment as well. I feel like that's a really thin needle to kind of thread when you've got it. How do you keep all of those stakeholders happy in terms of, we focus so much on the importance of workflow in healthcare and consumer preferences, and then we look at what's happening elsewhere in the world too. Do we draw inspiration from other parts of the world? Do we steal ideas and copy and paste? In Australia, we've got that opportunity to say, well, this looks relevant to us. I'd love to get your thinking on how do you keep all of those relevant stakeholder requirements in mind as we build towards these on the floor needs, as well as this big picture approach as well.
I think, which Daniel are you talking to?
Oh, sorry, Daniel. We'll say Australian Daniel McCabe, please. Sorry, but also
Thanks, Peter.
Dan's perspective too.
Oh, look, it's a really good question. I think it's fair to say we're late to the party in terms of what we're doing with fire. We only really started looking at this in anger in 2023, and we've actually looked across the world and I guess looked at a lot of lessons learnt from other countries about what's worked, what hasn't worked, and then trying to apply it here locally. And I think we have to continue to have that conversation and keep connected with all of our international colleagues. But for us, we also need to be very focused on what we need to do here in Australia to support the needs of Australians and our healthcare system as well. And I think that is the balance that we're trying to make. We've been very positive about the community engagement that's happening here domestically, with industry, with health professionals and with consumers in really mapping out what this might mean in the Australian context. Every health system is different. In our context, we're very fortunate that we have the My Health Record system, and we just had legislation go through the Parliament back in February this year that introduces the concept of sharing by default and actually requiring health professionals to share key pieces of health information back with consumers. And so I guess with that in mind, I think we are looking at how we then leverage all of the work we're doing through Spark to make sure that we bring these two concepts together. We think about what levers we have to make sure that consumers are empowered with having access to their health information. But how do we make sure that we do it in a useful and nationally consistent and internationally consistent way? And that is the sort of thread that we continue to balance. I guess my final reflection is industry has been hugely helpful and contributed significantly into this work. And I want to thank them for all of their efforts, but it's also useful for them in terms of being able to sell products into other markets. So I think that's the other thing that's really important in all of this work, and making sure we don't try to go by ourselves. We look at what everyone else is doing and leverage and steal as much as we can.
Sure thing. No, great perspective. And it did remind me of a comment that Michael Hosking put in the chat there through one of the sessions, just to your point around, what role does legislation play? And as Australia is kind of evolving to, the point around mandating standards. And if I took that theme and I went to Abhi for a second, from the Canadian perspective and your reflections, Abhi, what role do you see the role of, say, legislation and mandating standards and the importance of that in this approach?
Mm-hmm. Yeah, that's a great question. I think we have come to a realization, and we're probably late to the party, that incentives alone, would only take us this far. So there is discussions both at a federal level, but also at a provincial level to bring some legislations, when it comes to mandating, certain health data standards, but also the safe and secure sharing of the health information. I can speak from a federal standpoint. Last year, before we actually went to the election, we did establish or launch the proposed Connected Care Act, Bill C-72, which is modeled very similarly around some of the legislations that you have seen in US and in Europe with the European health data space. And it went to the parliament, but when we went to the election, the intent of the bill was really around, making sure that, one, I think the access to the health record could be maintained, and the second is the information should not be blocked within the health IT systems. Our plan is, now that we have a new government, we are going to work again closely with the federal and the provincial governments to make sure that we relaunch the bill and bring it back to the parliament. Maybe it's in the same form, or maybe we have learned something more. So usually how we're going to do this is we're going to consult the private sector, but also the public sector. I think that's something we're going to do to make sure that and I think there's a lot we have learned more in the AI space as well. So we're looking at that as well. Is there anything that we need to tweak in the previous bill that we proposed, or do we need to make any more changes to make it even more tighter or more prescriptive? So there is clear intent to reconsider that.
Yeah, absolutely. Hey, I'm here talking about that's so challenging about engaging all of the stakeholders here in Australia and the size of that problem, and definitely that's no mean feat. And then I look over at Steve in the US, and he's kind of probably thinking, oh, that's cute. Because of the magnitude of population and everything on the US side. I'd love to get your perspectives on this approach of you need to have a top-down approach, but you also, through that, you don't want to lose any meaning for those on the front line, and most importantly, the consumers, right?
Yeah, absolutely. And I know we were talking about the timing of different parties, so I think we may be impatiently partying here, because I feel like the timing was probably okay since I did my timing slide earlier, but not fast enough. And then, exactly as you were leading in, Peter, we have over 5,000 hospitals, several hundreds of thousands of clinicians, office-based physicians. As good as we have seen results from our earlier incentives in the 2010s for electronic health record adoption, we still know that there are aspects of our care continuum, behavioral health, mental health, long-term post-acute care, that do not have the same technological capabilities as your metropolitan hospitals. And so looking across that, you could call it a little bit of a digital divide. Looking across that, we're trying to make sure that there is a consistent baseline known to the healthcare community and accessible and leverageable, for lack of a better word, both for that patient access side. So no matter which healthcare provider you go to, you'll be able to get your information electronically. We'd love for that to happen, on apps on your phone via Fire. But in other cases, it's still accessing a patient portal. There's a lot of work that you have to do. And so, the kind of federated, disparate nature of our healthcare system adds a degree of difficulty, when it comes to stitching all these pieces together.
Absolutely. And Dan, the HL7 International Dan, we're all Dans here. I guess that ties together, what you were speaking about in your presentation, right? The importance of the legislation and in relation to standards. Any other additional thoughts from your side?
Yeah, I mean, I think there's a way in which, right, the work of our standards development is a technique for seeing a policy objective become real in systems agreed upon by the stakeholders that are, both developing those systems and using them. And so the role that a group like HL7 plays is, that of sort of a neutral convener of those different participants. But I think it's crucial that both we have participation from government entities, around the world. It gives them an ability to sort of provide voice to the most common and pressing priorities of from their perspective, but also a sense of understanding kind of where the industry is, where that sort of that sort of fulcrum point is, as Steve is trying to pinpoint, and others around the world are trying to pinpoint, where is industry ready, sort of where can they get to with a little bit of a push. You don't want to jump sort of too far ahead and make it too high of a bar for folks to get to from a policy perspective. But as standards development organization, we're listening to that feedback and the feedback from the industry about what are their priorities in solving interoperability problems. And that kind of results in the slide I showed around use cases of Fire from this year. You see that there's lots of different interest areas that are coming together now that there's a certain degree of having established sort of that foundation of Fire. Rewinding the clock 10 years ago, we didn't quite have that sort of foundation in place as well as we do now, but we're beginning to see the next step evolution from the industry. But clearly, that sort of back and forth, the sort of on the ground application, as well as the high level sort of strategic objectives from government entities, it's crucial to sort of have both of those things working together hand in hand.
Yeah, 100%. Hey, the what I love about the Spark community is it's a big group of doers, and when you've got a big group of doers in the chat, there's really hyper specific questions, and but that rightfully so. And just looking here, because I feel like, particularly from the Australian side of things, there's questions like from David about wondering whether the Canadian patient summary will look like the Australian version. Michael's asked a good question around the Canada's e-referral journey and lessons there. I might pause there because we've got others too. I saw Chris has thrown one to Steve too, and the speakers here can see those coming through on the chat as we go. But if I was to come back to Abhi for a second, just generally, there seems to be a fair bit of interest through your presentation on I guess the alignment of the synergies between Canada and Australia particularly, and we're in this position where there's a lot of lessons we can learn, or perhaps advice or reflections you might provide. Given those examples from the chat and anything else that comes to mind, have you got some advice to share?
So just to recap, some learnings around patient summary and e-referral. Yeah. Okay.
Yeah, sounds great.
Yeah, and I was keeping track of some of the questions. Both, I would assume both Canadian patient summary and Australian patient summary, they have been modeled on IPS, which really I would call it the baseline standard. And it just so happens Steve and I would both actually chair that global table for IPS, and we are working through setting up a strong international governance around IPS. So I think we have to recognize, when IPS was developed, it was developed with an intent. But I think when we looked at the local requirements, some of the specific information that we need to capture as part of the patient summary. So we had to look and address some of the local needs within Australia and Canada. So we're trying to figure out how do we roll up some of those nuances or changes that we have introduced into our versions, and how does it all roll back into IPS, which is something that Steve and I will have to figure out over the coming months from a governance standpoint. But to answer your question, yes, they both follow the same parent standard, which I would call IPS. On the e-referral side, that has been a very interesting journey, and we have learned actually quite a lot over the last 2 years. We did not have a pan-Canadian national standard, and we left it to the private sector to come up with their own e-referral solutions. And very soon we realized that, given that, 13 different provinces that we have in one federal system, everybody was trying to scramble to procure solutions from this private sector. And we realized that, it is actually going to create lots of inefficiency within the system, which is why we came up with, we worked with those vendors who had their solutions together, and we tried to rationalize and come up with one standardized solution, which actually includes both FHIR-based and smart on FHIR-based exchange. From within the EMRs and within those e-referral, I think the lessons learned was you have to address both point-to-point directed referral systems where the physicians would like to actually send to a specialist that they know, but also a central intake model where the physicians may want to actually send it to the central intake system, and the central intake system should have the ability, based on the demand and supply guidelines or demand and supply principles, to actually assign the referral request to the earliest available specialist. So you can imagine those are some of the things that we learned when we went through the workflows. And so today we have a national standard which addresses both the flavors, the point-to-point as well as the central intake. Our team member I saw was actually putting some hyperlinks into the referral chat. Both those standards are available through Infoway's website, so I would encourage you to go and review that. And if you're interested further, we're always happy to do a session with interested folks.
Yeah, it's great to have those resources there. Thank you, Abhi and team. As I look at the time, I want to make sure we get the most out of having you important people on the screen with me, and looking at a well-emojied comment here in the chat, which reflects people's interest in the question. I look to Jason's question around managing medico-legal risk, and I've put that up on screen. But if I was to paraphrase, or at least thinking about the questions I think about too, I guess on one hand, if we think about mandating data sharing, and if you don't do this, then you're going to break the rules. But then also, if you share the data and you do it wrong, you're going to break the rules. There's a lot of rules around, and there's and I guess an element, one unique element around healthcare is that often the risk may end up falling on the individual clinician themselves, and they're the one kind of holding the ball, depending on what's happened, given the nature of what we do in healthcare. So I'd love to have any thoughts and reflections from around the world, and the participants from their experience and reflections on how you balance that medico-legal risk with the needs for data sharing. I'm going to throw to Steve, but if there's any others.
All right, I'm ready. I'm ready.
Yeah. You looked ready. You looked ready. So I thought I got that vibe.
That's good.
Yeah.
This is when I get to do the preface that this is not legal advice first, right? I'm not a lawyer, but so the question really raises a number of interesting facets, at least in the U.S. healthcare system. So you've got an element where individuals have a right to access a copy of their health information. You also have a right to request amendments. So there can't be a wholesale change, but there's a process where we can go through and identify that there's an error, in which case we see with more access, with more information available to you, then you actually notice that some things get recorded erroneously. And that's a benefit, that's a feature, not a flaw, to the system from a transparency perspective. But at the same time, I know this isn't an AI talk, but we've talked a lot about how interoperability, how information sharing will change the standard of care as there's more information accessible to our clinicians. The same thing is true, from an AI perspective. And so a lot of the way that gets worked out in the United States is medical malpractice, other types of, court cases that then create the precedent for how a certain behavior was supposed to go. Now, there are a lot of clinical associations and other types of consortia that are putting forward best practices to get ahead of those types of, legal issues at the end, as a byproduct, I would say, of something bad happening. So we're hopefully trying to move forward with better quality lessons learned through the active engagement with the stakeholder community to get things kind of going. But ultimately, I guess my experience has been that we see these things come out in court cases at the end of the day that really set the kind of change of pace or the direction for the industry.
Thank you, Steve. Looking at there's plenty of other questions and comments coming through. And Steve, thank you, and others participants who I can see are also commenting in the chat, or it's your AI agent. I am not sure, but it looks like it was you. So that's amazing. What I might do is Nick's asked a question that's also been well emojied, which is, I guess, again, looking at lessons around the world. It touches on themes we've already talked on too. But if I was to use this question and to throw to each of the panelists before we close out, perhaps for 1 or 2 minutes, final thoughts, lessons, reflections, given what's happening around the world, and what we might take selfishly here in Australia too, but that others that are joining from globally, as we continue to build out these standards that are relevant, not just here locally, but align globally. I might come back to Daniel McCabe, as I haven't given you a bit of airtime for a bit, and you can kick things off, and we'll go around and we'll close off. We'll bookend with Daniel's. How about that? So over to you, Daniel McCabe.
Thanks, Peter. Well, it's a really, really good question. And I think that's a journey that we're just getting into now in Australia in terms of we're building out all of this digital capability. We've got a really good community of clinicians contributing to it, but that doesn't do enough to actually make that real for all clinicians. And I think that's our challenge about how do we make sure we get more clinicians engaged in this agenda, what it means for their workflows. I think often we make assumptions that, we've got a group of very tech-savvy clinicians involved in all of our design, and that's going to be applicable to all. And I think that's something that we've got to keep working on. We've got to keep communicating. We've got to keep testing concepts. This is not easy, but it's got to happen through lots of engagement.
Yeah, love it. We'll come back to you, Steve. Any other final thoughts, comments, reflections?
I think, the one thing that many of us have already mentioned, it requires active engagement across, the different groups in our various jurisdictions. That's how we're successful. Anytime we try to move fast as a government, without that support, we wind up having, hiccups along the way. So that's, at least a lesson learned that I've embodied now with more time and experience.
Yeah. Love that. And Abhi, I'll throw to you as well, particularly in the context of those lessons around, because communication, that's often where we can have the best technical standards and all the rules written out, but then it's got to translate as well, right?
Yeah, I think we've learned the lesson the hard way. I think traditionally, we often took the standards approach to solving the problem, but I think we have learned hard working closely, with the clinicians and the patients. And I think the element of the co-design, I think that is extremely important, because I think all the data standards and exchange standards are fantastic ways to get somewhere. So I think we need to first define where do we want to get. And I think it's a mechanism to get there. But I think so we need to define the destination and the outcome that we're trying to accomplish, and especially in the current scenario where AI is fast integrating, or I would say forcing itself into the healthcare. We got to make sure that we take the clinicians who are the users and the patients who are the receivers of the information part of the co-design as we integrate AI. And I think that is the best way to earn their trust. And we're demonstrating the similar thing in Canada, especially with our AI maturity strategy that we have developed on how to safely integrate AI into clinical practice for non-clinical tasks, and then eventually integrating into clinical practices for clinical tasks, but taking the clinicians along with us. I think that's a very important part.
Yeah, totally. I mean, that's the case, isn't it? That there's, it's one thing for the existing standards and things that we've built, but in a world where technology is moving faster and AI and large language models, the opportunities that presents, we're going to continue to need to get that part right. Dan Vreeman, I'm going to pass to you for any other final comments and thoughts for this panel.
Sure, thanks. I think my my other panelists covered many of the things that I feel like are key, including dynamic and iterative engagement at every sort of step along the way. We routinely now ask questions in standards development that are reflecting around, burden. Where is this data element expected to come from? Is it readily achievable in the systems we have, or are we somehow going to have to do some type of transformation of some kind? And is that going to make things easier or harder for system implementers? We now have many of these fundamental building block technologies that can advance the dream that many of us have had about making things better, faster, and easier for clinicians in terms of advanced clinical decision support that's operating on a very full picture of the patient that I'm trying to serve as a clinician. Whereas, it wasn't too long ago, and we were having major gaps in what the system actually knew about the patient. We're incrementally getting closer. But along with that, in the introduction of such a radical technology like AI, we realized that the way in which those kinds of systems interact with the clinician making decisions, we're still learning about the kinds of information that people, humans, clinicians, patients, caregivers, others will find trustworthy. What are the attributes of that source data, of the model development, of the cohort and the training data, et cetera, need to be surfaced in order for decision makers to feel confident in recommendations or outputs of those systems. And from the standards development perspective, it's having at the ready those attributes as data elements and as features and summary metrics and so forth that can surface them to people. But that's exciting, in terms of where we are now and where we're seeing the future going, is that we're at a place where these transformative technologies can operate on the kinds of health data that we've imagined, systems having the capability to do so for a long time.
Yeah, totally. Look, that's a great way to frame out and close out session 1 of the Spark Symposium as we fire around the world. Thank you, panelists, so much for joining.
Thank you.
Okay, well, we're just kicking off session 1 of the Spark Symposium. Oh, oops, sorry. That's we'll be back at 10:45 a.m. It's currently 10:30 a.m. Australian Eastern Standard Time. We've got a global audience, so in about 15 minutes, we'll be coming back for session 2 for the Australia on Fire session. During the break, leave your browser open. The stream will be here. You'll be able to have a look at the participate in the next Menti session too that we'll just bring up on the screen now. And that one will be up in your Menti browser, which you may already have. It's relevant to the session that we just had too. If you've not used Menti yet, just jump onto menti.com. You can also use the QR code, which I'll try and bring up in a second. If not, just put the code 79654175, and we can see those answers coming through. We'll let that run through the break for a little bit and then come back in about 15 minutes and we'll chat more then. Excellent.